They just walked us through. So it just interesting. Everything she said is about we don't get improvement in pain, so behavior review she's been look still haven't the crisis house
with different awards, trying to shortlist them. Finally, you'll see the changes to different portfolios in the executive team detailed. I won't go through them all there now, but I do want to acknowledge that this will be Peter's last board, because he is stepping down from being the Chief Medical Officer on the 28th of October. He will still be working with us until the end of December. And Oliver Dale, I had his fit and proper person test at 12 o'clock today. So I didn't think I was going to be able to announce it, but I can announce that Oliver Dale will become our Chief Medical Officer on the 28th of October. So I formally want to thank you, Pete, for everything you've done and how you've driven us to a evidence-based and research-driven organisation. Thank you.
Thank you, Jen.
Very good. Thank you for the report. It's a good report. Thank you. Also, Peter, thanks very much for everything you've done. And for that last point about evidence-based and research orientated organisation is so important. So thank you very much. Yes, Dan.
I was just going to add to your point about, in the context of all the changes and the challenges that we're seeing across the NHS, it is all the more important to celebrate what's going well, which is why these Positive Practice Awards feel very important this year. And it's great we've had so many nominations in. And so, as the CEO said, it would be great to have as many of the board there as possible.
Yeah, a couple of points. I was really interested in the idea of the secondary prevention being so important as well. I think that's really important, huge opportunity for us, and quite interesting listening to Pip's story about if only somebody could intervene before she gets right down and set off. So really important stuff. But on the discharge bit, the problems in finance to local government, how much can we help them with work about the impact of delayed discharge will ultimately cost them more, in that people will be more decompensated and require more complex care packages? Where's the work to do that sort of analytical work to help them?
And I'm pleased to say I've got an answer to that. So that is, you may not know, but Adam Doyle is a physiotherapist by clinical background.
Okay.
So that is one of the work streams he has explicitly put in this new piece of work for the system. So it will be looked at, and I think that's probably an area that hasn't been attended to historically, but it is something that is being brought forward.
Excellent.
Yeah.
There are big costs associated with not doing
Exactly
stuff in the community, and then the pressures then in our services, which would the acute inpatient sector, they're much more expensive. So you've got to get that right.
Yeah,
that's good. Thank you, Kathy. Anna.
Okay, thank you for your report. What you said in a short time period, what struck me, amongst many other things, is the considerable competency of the executive team. But you've just described it as tough. It's down from 10 to 8 in terms of headcount. I'm sure you've thought through this night after night. If it transpires, with the best will in the world, that executive colleagues are at their or beyond their elastic limit in terms of their bandwidth, is there a plan B? Is there flexibility elsewhere in the team?
So we had a senior leadership team meeting. We have 40 senior leaders in the organisation, and we're investing in their development as a group. And I think that's where the elasticity is being built, because I think as we're developing as a team, because 2 years ago we were not a team, and it's only since the last year we've all been in post. I think we're now in a position where there's a lot more delegated leadership and a lot more strength in our senior leaders to be able to support them. And I would be advocating for developing and strengthening that layer rather than the exec team, and maintaining the exec team as it is.
And how does it feel, the exec team? Let's come to a couple of people. I mean, Colin and Usman.
I would agree with Jane. I think there are benefits to having a tighter executive team, but we're only going to be as successful as our teams that sit underneath us. I'm very fortunate to have had the chance to recruit most of my team, and I'm very pleased with who I've got. But I think there is something about how we start to move into a much more delegated model of responsibility, from a model that I think historically has seen everything kind of coming up to the executive for decision making, and that will require a change of our behaviours to enable it.
Please,
yeah. No, I just wanted to mention and this was just before I came into the trust, that the move to place and the importance of doing that move where we have our West East specialist and Brighton and Hove divisions and the creation of the triumvirate. So within that, we have the MD, the CD, and the Director of Nursing and Quality, and those are brand new roles that were put into the structure, as it were. So to just an extension of Jane's point around leadership, there is going to really be that, almost like being the chief, the crew, the CMO and the clinical directors of their own part of the world, if you like. And there's something about, not just delegating that authority, but us then role modeling what that looks like in behaviors and expectations and in ambition for them to carry on. So I think it's not to be one.
Anil, good?
Thank you. That was a really important challenge. I thought, well responded to. I just want to ask under 9, Jane. So the progress at the emergency department at Sussex County Hospital, whether we will get further updates on how that is progressing.
I can update you on that now. The EOU has been closed, and we have moved all patients out of the EOU, and we are caring for them either in the community or in ED and trying to reduce them. We now, at the length of time they're in there, and we now have a standard operating procedure that we have agreed between us, the University Hospital Sussex, and the ICB around escalations for patients who have been over 12 hours in ED. So that work has completed now. I spoke to our Freedom to Speak Up Guardian Monday, and she's going to go back to the people who raised concerns to check that they are satisfied to close the Freedom to Speak Up appropriately, but rightly she wants to make sure that they are satisfied with the evidence that we provided.
Right. And will you bring further updates to us?
So I think that will be through Quality Committee. Yeah, thank you.
And on that very subject, the Quality Committee, we're moving on to your report. Yeah.
Okay, thank you, Chair. So I will take the report as read. You've got 3 annual reports plus the mid-year staffing establishment review in this section, and just briefly to comment and then happy to take questions. I think, as we've already talked about earlier, where QC continues to learn from the wider environment as well, and notably at this meeting, this most recent meeting, the Calcane case in Nottingham, and exploring this happening in Sussex. And I know Tracy are going to talk about it shortly, but I think just to note that we talked about whether our outreach teams were able to meet needs in the community, and about how the risks in the community remain high. So something that we certainly are keeping an eye on, and will continue to keep an eye on the committee. On safety, we welcome progress on the quality priorities. Very pleased to see no inpatient suicides, reducing ligature incidents by 50%. Involvement of families progressing well in terms of involving families following serious incidents, and I think we continue to note progress with care plans, risk assessments and outcome measures. Although we're not there yet, we can see the progress that is being made in those areas. And then on the staff side, we noted the continuing fall in vacancy rates, along with some progress on turnover, certainly sickness rates. I think we certainly wanted to continue to escalate concerns about the lack of capital funds for safety. This is something that, hasn't gone away, is very complex, and, isn't going to have any quick fixes. And Teresa, you drew our attention to another important ongoing concern about the lack of national benchmarking data, particularly on falls amongst mental health. trust patients, and that's something, we need that national benchmarking in order to better understand ours. In our own rules. So finally, just to note that we are compliant in terms of the IPC infection prevention standards. We are compliant on medical revalidation, and the rotas and working hours for our doctors are managed safely. That's all I can say. Teresa, you want to?
Yes, Teresa, would you like to? But firstly, thank you very much. Great report, and thank you for sharing.
Thank you, Chair. So two points on in response to a couple of the things that Anna said, and then I can talk more about the Calico case if you'd like me to go straight into that, Chair. So Anna mentioned the work that we're doing with families, and I think it's really important for me to say that we haven't always got this right with our families. So we are doing a piece of work currently to look at our PSIRP, so that's our Patient Safety Incident Response Plan, which is due for review currently, and making sure that we take the feedback that families have given us where it hasn't worked well for them and incorporating that in our systems and processes as we go forward. So that's one thing that I wanted to say. The point that Anna raised in relation to the national benchmarking. So falls is benchmarked nationally and reported nationally in acute hospital trusts. It's one of their key metrics. But for mental health trusts, falls isn't a metric that we are required to report on. And actually, when I've looked a bit more closely at this, there are a few metrics that we might think are required to be reported nationally that aren't. So it's a conversation that I've had with the region. And it's a conversation that we're having through the Mental Health Nurse Directors Forum. And there'll be more work that we're going to do to promote that, to take that forward. So I just wanted to share that key point also with the report.
Yeah, good idea to take it through the Nurse Director Forum. That's very active, isn't it?
Yeah.
Good.
Yeah.
Did you want, shall we go into intensive and assertive community mental health treatment?
Will do, thank you. So we've mentioned times today, both in Jane's CEO report and also in the report that Anna has shared about the CQC review of Nottingham Healthcare NHS Foundation Trust. So this review was commissioned under Section 48 of the Health and Social Care Act following the conviction of Aldo Calico in January this year for the killings of Ian Coates, Grace O'Malley Kumar and Barnaby Webber. Ultimately, one of the actions that has resulted in is a request to the ICB from NHS England and provider boards to ensure that we have appropriate governance, partnership working arrangements and monitoring systems in place to identify individuals in the communities that require intensive and assertive community care to meet their needs and to keep them and others safe. And this is a group of patients that often have a diagnosis of psychotic illness and are sometimes at risk of being lost to follow-up or discharged due to non-engagement with services. So we were required to complete a maturity index self-assessment tool, and the questions in that tool really helped us to consider how assured are we around the visibility of the care and treatment of people that may have a psychotic illness and that might be diagnosed or not. So we did a big piece of work with our operational and clinical colleagues out in divisions to look at this in some level of detail. So far, what we've ascertained is that we are reasonably assured by the care and treatment and the visibility of the care and treatment of patients that are sat in our community rehab teams, assertive outreach teams, forensic outreach and liaison teams, early intervention for psychosis teams, and child and adolescent mental health service assertive outreach teams. So we are reasonably assured. The area where we are partially assured is through our ATSs, so our assessment and treatment services. And when we looked at the feedback from our operational and clinical colleagues out in services that led to a partial assurance rather than full assurance, is that there were some gaps identified that require action to improve the assurance in the ATS provision for this cohort of patients. And as you will have seen in the report, and I am going to list them because I think they're really important, assessment and management of risk, we are partially assured on, good quality, effective engagement with families, quality of the care planning,
record keeping, variation in practice at the point of triage, clear recording of diagnosis, the use of the access and active engagement policy, and the resource to provide the required level of service and to meet population need. So what are we going to do about this? We're going to host a task and finish group, and that is going to be led by our Director of Clinical Governance and Quality Assurance, where all of those areas that I've listed are going to be subject to interrogation, to review, and show a really clear action plan. And that action plan will come through the Quality and Risk Management Committee that Peter and I co-chair, and then reported up to the Quality Committee. We will provide an assurance paper to board in December in relation to that work.
Thank you. Thank you. There's a couple of questions. But this is a complicated set of reports of the Quality Committee. So if I can just, I will come to the question, take stock just for a minute. We need to we receive the quality report, we need to receive the mid-year staffing establishment review and the infection prevention control annual report, all there for you. I will come to Owen and Peter in a minute for two specific medical parts of it. And let's just take stock. And Abiola.
Thank you for that report. I've got two questions. The first one is to do with point 6 that you had in your report about the mixed sex, accommodation. And so what sort of, came to my mind is that I know that within the LGBTQ community, especially people who, are struggling with gender, maybe not struggling, but, how are we meeting their needs now that we've decided that we're definitely going to have separate accommodation? So recognising that there is a high incidence of mental health issues in that community.
Yeah, absolutely. Thank you. So our recent review concluded that what we want to have, and we are having, is a combination of mixed sex wards and single sex wards. So that's the first thing to say. For the needs of transgender patients, patients will be admitted usually to either a mixed sex accommodation ward or to a single sex accommodation ward, depending on their needs and depending on the level of risk. In our new hospital, Coombe Valley, there will be, the way that those wards have been designed is in such a way that there are a couple of rooms on each ward that are quite central to the central hub of the ward. So if we're operating those wards where we have one corridor that's for men and one corridor for women, and the person identifies as trans or is going through that process, then they will be offered a room that is as central to the middle of the ward as is possible. So we do have a transgender policy that has been updated recently, and actually had a patient story here that some of that outcome a few months ago. So I hope that's helpful. I'm very happy to talk to you more about it.
No, thank you. I appreciate that question. And then my second question, which is to do with the how we got the issue in in Nottingham, and then linking it back to what was in Jane's report about how we're having issues with what we're sharing with families. So I know that in that report, the family have alleged that they didn't know everything about the man's issues. And so now we don't have full assurance, only getting partial assurance that, in terms of what we're telling our families, we're not so sure. So just, it's not really a question, it's just sort of linking the two and saying, when you do review that, can we make sure that that there is clarity on that, because that is something that's coming out in the other, in that case.
So Abiola, we have taken some action on this already, and Pete, I think you want to come in probably thinking the same lines.
Go.
No problem, it's fine.
I just wanted to take a slightly different approach to the answer, so you might want to answer that, speak to that point first.
Well, I was going to talk about the letter.
Please, talk about that if I may.
So there was a letter that clinicians across the organisation found really quite helpful some years ago in relation to the commitment of the organisation to support staff in having discussions with families around, for example, different diagnoses, things that help, things that don't help, without breaching the confidence of their loved one. But also saying that we would support you if you are having to take an urgent action to preserve and maintain safety in the immediate term. to potentially breach confidence. If it's in immediate safety. So that letter was sent, I think, a few years ago, Jane, wasn't it? And we had cited that letter fairly recently. And given everything that we're talking about here today, we've updated that and we've sent it back out. Pete and I also issue a CNO/CMO newsletter on a monthly basis, and we've made reference to that in that newsletter too.
So just so that I understand, it's only in an emergency that patient confidentiality is breached. So, I'm just wondering how we involve families in the care then, because if families are not fully aware of what they're dealing with, how can they bring, their cultural aspect, their religious aspect, their, the assets that that patient has and the family has and that community has to meet that need if they're not fully aware of what's happening?
I think what we're talking about here is a whole spectrum of work. And I'm thinking about the video that's being made or has been made in relation to the care and treatment and how we engage with families.
Yeah, and exactly that. And I think the point about it being on a spectrum is really important. And I'd come back as well to the feedback we get through complaints, where communication is one of the key reasons why family members in particular complain, and it's often about not feeling informed or not feeling clearly informed about the pathways of care. So I think there are a whole range of actions we need to take, and I'll take you. But the one that Teresa mentions includes a bespoke online training package that we'll be launching on care involved.
It's a really important question. So many times, again, I was talking in my report about national inquiries and reviews. And often the core is that families didn't feel involved, didn't feel informed, etc. So we need to get this right. It is a journey. Pete and Jane, then we'll move on.
So if you remember, we had a story to board within the last 6 months, which was all about a mother whose brother had taken his own life with schizophrenia, concerned for his son. Very great deal of difficulty she had because her son refuses all communication with the mother, and he does that when he's well. And he sets it out in law, and he's very clear about what his wishes are to be when he's unwell. And he does not want his family to be involved in that conversation. So we face this a lot of the time. It's why we have Caldecott Guardians, and why we have an IG process. It is why we work tirelessly with our clinical teams to encourage them to push the envelope as far as possible to an inclusive conversational space. There are ways of helping family understand the principles of our care when people in our wards will not talk. We teach our staff to think about how we can get the messages to families that families need to receive. But quite often we are caught in a legal bind, and we're not caught in a legal bind when people are ill. We're caught in a legal bind when people are well. Usman made me very aware, though, of something that might be materially important to this board, and that is how poorly chief finance officers understand the condition of schizophrenia. I put it out there because it was the best piece of feedback Usman, you gave, which was when you said, well, wouldn't all people with schizophrenia be cared for in an assertive outreach team or an enhanced recovery service? And I think what was important to me was that we as an executive, clinical and non-clinical, then understood something about the condition that is schizophrenia, which was Callaghan's diagnosis. And that it's entirely possible to live in the community supported by your GP with schizophrenia. And many people with schizophrenia are adequately and well supported by an ATS. But it's the kind of situation that we're discussing here, where as part of the disease, as part of the abnormal mental state, the person becomes unable to appreciate that they need care when they need care, that we then get into assertive models of treatment. And really the whole conversation here is, so when somebody doesn't want treatment and doesn't want their family involved, because of the delusions of persecution, the paranoia and the mental illness that they're experiencing, how do you then build an assertive model of care that is compassionate and containing and sensible and safe, when actually what it really means, if you want to live our experience, is tracking them to the dole office, sometimes with the police in tow, to compel people to do things they really don't want to do in quite dangerous situations. And that is what mental health work is like when you're a registrar in Tooting, or when you're out and about in Bognor Regis, even at my late age. So I just think everybody in the board might want to at some point have a think about how well they understand the conditions we're treating. Because it's pretty fundamental, isn't it?
I wanted to extend the time we had on this because it's so, but it's quality, it's about quality, it's the core of what we do. I'm going to take Jane's point. I know that Catherine Allen wants to come in, going to bring the two reports, hear back from the two reports, and then we'll get your questions at the end, Jane.
So two things I wanted to say. We have the triangle of care here, which sets out the principles of we're externally validated on the triangle of care, and that reports through to quality committee. So we have some assurance process and plan around how we improve that. The other thing is, I think service user involvement, carer involvement, breaching confidentiality are all different things. They're all involved in the same thing. Hearing is not the same as breaching confidentiality. And one of the things this letter said is you are not breaching confidentiality if you listen to the family. You can listen. You might not be able to share anything back, but you can listen. And that informs the risk assessment, which is the important bit. So I think we're conflating lots of different things that are all really, really important. But I think this is something that is assured through the quality committee and the experience side of things.
Right.
Great. Medical evaluations, Eleanor, welcome. Thank you very much.
Sure. And good afternoon, everybody. So this report is the annual board report and statement of compliance for medical validation. It's the annual report we ultimately submit to our regional NHS England office. The ask of the board is that if you are sufficiently assured by the assurance provided by the reports that I'm Chief Executive Officer, so that we can then submit that to NHS England by the deadline of the 31st of October. I will take the reports, but I'm very happy to share provide some brief updates or bullet point updates to share if that would be helpful.
Okay. Okay, we'll do that. We'll put it through and get it signed by the Chief Executive. Thank you, everyone. Thank you for your time.
Thank you
very much. Thank you.
As the person signing the report, it's made very easy because of the clarity of the report. So thank you.
You good?
Thank you, Jane.
Yeah, no, excellent. Thank you very much. And Guardian of Safe Working Hours annual report, Peter.
Yes, thank you. So I'm here. The paper is there to be read. It's been through the committee structure. The Guardian of Safe Working Practice and I have an arrangement whereby if there is issue of complaint or concern, she has every right to be here and be present at the board to speak to the paper. If she tells me that there's nothing to worry about, she's very happy for me to present the paper on her behalf. So I'm delighted to say that all fines have been paid. That was a slight issue. The last time we met, there are no other further concerns. All processes seem to be running well. Nothing to see. I recommend the report.
Thank you. It's received. Thank you very much. Yes, Kathy and Anil wanting a question. I realise it would be Peter's.
Well, I guess I might be able to demonstrate Peter's point and plumb the depths of my ignorance, but it was really sort of looking at that report and then looking at the information we had about suicide and thinking about when people are transitioning in their care. So there was one example of a patient, I think, where they were discharged with the recommendation to self-refer somewhere, which they then didn't do. And then there was another where the GP had referred into the service and the service deemed that probably that patient could be managed in primary care. But presumably primary care didn't think that because they wouldn't have referred in the first place. So it was really around those transitions and how do we know when somebody has landed where we think we sent them and that they've been picked up. It's that bit really, and I wasn't sure if it related to that or not really, but it's the same principle. How are we making sure that people are moving through the system and landing safely? I think about this because there's a lot of people who are involved in aviation in my family, and when pilots swap control of an aircraft, they go, you have control, I have control, and you know who's flying the plane. So I kind of wondered if we've got that sort of safety mechanism when we do transitions for people.
I would probably look at Peter and Trill for that one. Yeah.
So I think the key, if I may, the key anxiety for me, which we have looked at through the lens of our former clinical director, Claire Tanner specifically, is the issue from Callacane on when is it appropriate to accept a person's judgment that by not showing up for care on a couple of occasions, it is reasonable then to write to the GP and say, so did not show up for care for 2 appointments, we're therefore returning them to your decision, which would be completely normal in the general hospital system. And is actually quite appropriate for many of our services where people are competent and able to exercise those decisions. Where it's difficult is the territory that we're creeping into, which is actually when should you be curious that somebody has not attended for care because they're becoming paranoid, strange, socially anxious, avoidant, or are in danger or physically can't make it. And so that's the work that we're doing at the moment through this lens of considering where is the assertive outreach function. in each of our teams and how competent are each of our team models at exercising it. So you would expect in a sort of outreach team to be 100% at it because it's what it's designed for. You would expect our enhanced recovery models to be pretty good at it, if not 100%, because that's what it's designed for. When it comes to an ATS, it is not so certain that all of those teams are equally positioned to do that work well. That's the partial assurance piece that we've highlighted to board, and that's the area of work. And we think we'll work it out through the integrated care, the integrated community neighbourhood team work that we're doing. That's where we're seeking to get the solution to that.
See that,
That's helpful.
yeah.
Okay. Thank you. Anil, brief question?
So this comes with the cautionary preamble that Carrie set out. So of understanding, can I just probe that a bit more?
Yeah, please do.
So good, reasonably assured. One ATS, partially. You set out very helpfully a list. By their nature and the extent of the risk and impact on others, it seemed to me that that would have been highlighted previously. It's not on our risk register, presumably. Begs the question, if that's a fair and accurate assumption, why? Sorry, I'm looking at you, Tracy.
It's okay.
I give my fault.
So you're opposite me, that's
So the Claire will appreciate the history of some of this conversation. There's an excellent article in the Nursing Times by Chris Hart, reminding us all of what we've learned or partially learned over the course of 30 years. In this case, and everything that followed Christopher Clunas, which led to the National Service Frameworks for Mental Health, which produced the assertive outreach team model, which in of itself eventually became silted and was found to be less effective than reintegration of community teams and so on and so forth. The fundamental is the relationship between whatever we call the lead practitioner, the key worker, the care coordinator, or that key individual who looks after a group of patients, a group of people. How many of them have they got to look after, and how much individual time can they genuinely spend with them? And quite clearly, if you have got a lot of people to look after, you can do less for them than if you have a few. And most of these high-intensity models were based on reducing the number of patients that each key worker looked after. So that's very often what we're up against with partial staffing of units, safe staffing ratios, the number of psychiatrists, psychologists, and nurses, and so on and so forth we have. So really, it is through the quality committee and through that relationship between our people and our service models that we get assurance that we are providing sufficient care to the right acuity of illness sees us through, which is really good for our high intensity teams, really good for our EI teams. We've been hearing some brilliant things about them. The one area of concern across the country is how fit are teams, the ATS is full of purpose. And that's why we're reworking that model.
Yeah, it's really good set of questions. But Jane,
yeah, so I would argue that they are on our risk register, not on our trust risk register, but our directorate risk register, but not as an explicit thing like this. So we have got a lack of lead practitioners on there. We've got lack of challenges with having substantive medical staff, which then means they don't know the patient so well. And so there are elements. So I think we're aware of the risk. What the assurance process from NHS England has done is put a different lens on something we already knew was a risk and is always on our risk register. But what your question has made me think we need to go back to the divisions and maybe reframe that risk on their divisional registers, risk registers. It also comes under some of our higher risks as one of the elements underneath it. We're doing a board workshop looking at our risk appetite in November, and we can explore it a bit more there as well.
I like that. We'll do that as a result of your question, Alice. Thank you very much. Final point, Clinton.
I just want to bring in the point around our quality plan for the year. So you will recall through previous board meeting that our quality plan for this year goes to fundamentals of care. And when we compare the fundamentals of care and the quality plan work that we're doing this year, there is an overlap between that work and those areas that are highlighted earlier. So as the report says, a lot of this is already in train. But I think to Jane's point, it casts a different light on some of those fundamentals of care that we're currently working on.
thank you so much for that. Peter, do you want?
Well, it's just a very brief comment. The Mental Health Medical Directors Network,
Yes.
which the foundation set up. So I'm a member of that.
Yes.
And this has been a very live conversation.
Okay, good.
With many trusts saying we're in the same position.
Yeah.
We're re-examining the scope of our community mental health teams to make sure that we are covering this gap. So we are at the leading edge of a good place to be, really.
Yeah.
In my view.
Excellent, excellent. Thank you very much. I appreciate bearing with me for taking the items a little bit out of order, but we've covered everything now. For me, for the workforce responsibility standard, I think got a colleague coming in. You've only given me 5 minutes.
Yes. Yes.
Yeah, welcome.
Hi.
Welcome, Emma. Thank you.
Yeah, just.
Are you okay?
Yes,
Yeah.
thank you.
All yours, please.
Thank you. Everyone, my name's Emma Mendes da Costa, and I pronoun she and her, and Equality, Diversity and Inclusion Lead for the Trust. And I'm here today to present our annual Workforce Race Equality Standard and Workforce Ability Equality Standard reports, what I'll call the RES and the WIDDES. I'm requesting approval for publication on the Trust external website by 31st October 2024, and that's the deadline by NHS England's mandated standards team. Starting briefly with the RES, we report against non-indicators, and in 2023 to 2024, we maintained or improved our performance against 8 of those 9 indicators. Of note is a 4% increase in staff from racially minoritised groups from 14.3 to 18.3%, and a significant reduction in the likelihood of staff from racially minoritised groups entering on disciplinary processes compared to white staff, and that is down from 1.74 to 0.64. One indicator where the experience worsened was abuse from the public, which has increased from 32.6% in the 2022 staff survey to 33.8%. Moving on to the WIDDES, we report against 10 metrics, and in 2023 to 2024, we improved our performance against 3 of the 10 metrics and against parts of metrics. That said, we are performing above.
Sorry, just slightly volume up.
Sorry,
It's okay.
it's difficult for me to.
I know. If you want to move here, you can do, but I think it's just
Is it better?
a couple of decibels.
I'm going to say
that. As well.
Yeah, and there's some traffic noise and what have you. You've done very well. Thank you.
Thank you. I always think that I'm very loud, but I'm told that I'm actually very soft. Moving on to the WIDDES, we report against 10 metrics, and this year we improved our performance against 3 of the 10 metrics and against parts of metric 4. That said, we are performing above the 2022 to 23 average, the national average on all 10 metrics. So the note here is our high disability declaration rate. So last year it was 11.61%, and that was the second highest in the country. And it's actually continued its upward trajectory to 12.18%. Also of note is an increase in disabled board representation, 5.88 to 11. So both reports then include a summary of actions taken to address inequality in the last 12 months and a table of actions. All the actions taken and actions planned are in the Trust's Equality, Diversity and Inclusion 3.5 2023. Thank you for your time. I'm happy to take any questions. Please do note that I have bound bilateral hearings, so I may need any questions to be rephrased to review or actually respond.
Yeah, thank you very much. Really good report, and I'm positive. Report for me. Before we, do you want to add anything?
No, just to say that there has been incredible progress in the last 2 years on those two metrics that Emma's just spoken about. And one of note is the likelihood of racially minoritized staff facing disability. When I came to the trust, it was at 3.6 times as likely. And so there is evidence, and I'm always a big believer in impact and evidence-driven work.
Yeah.
And so the team working seeing results in 8 of the 9 categories is impressive, but again goes to show how much more work we need to do with regard to our disabled, our staff who have a disability, because that is the area where we still have quite a lot of work.
But thank you for the work so far to get those numbers down. That's Anna and Hill.
So this is a fantastic report. Thank you so much. And really good progress. It's good to see so much progress. I wanted to ask, standard 7 of the RES, 51.6% equal opportunities promotion for all. I suppose I wanted to ask, what are the barriers that we can break down here? And similarly on the DES on standard 8, you know, we're talking about reasonable adjustments, but we haven't quite got all the way. So I just wondered what your thoughts are, because you live and breathe this. What were your thoughts on the things that we still need to do better?
I think with regards to the RES, one of the key things we want to look at in the next 12 months is the development of talent management. One that specifically targets marginalised staff as well, so we can check them. We have just launched reciprocal mentoring trust-wide as well. I believe will make a difference because they are staff across the trust, so they can learn that more involve more senior staff championing of juniors. With regards to the WDES, it was WDES 8 we were looking?
Yes, the reasonable adjustment. So it's at 83.4% at the moment.
Yeah, we are considered to be leaders in the region. The reasonable adjustments already could be centralised on reasonable adjustments. That helps whenever a reasonable adjustment has a cost implication in trust. What I think we still need to do wider is a cultural piece, which is we have reasonable adjustments training that we started, but it's about a lot of the reasonable adjustments that don't justify. And it's around line managers feeling confident to put those adjustments in place for their staff.
Jane, just to add to that, and then the final question.
Thank you. I mean, one other thing I wanted to say is that we have a plan. I know that sounds a bit, but we have a plan that we've signed off here, and we are seeing progress against it. I think it's time to stay on the plan, which will report to Quality Committee, because we're seeing progress, and I think it's important for us as a board to say to Emma, we're right by you with this. We'll be working with you on this. This isn't sitting in the EDI team and then leading it. This is a board-led thing that we'll be doing with you. So speak up whenever you feel you need us anywhere, or we can be involved in any way.
Yeah,
so thank you.
No, that's really good. So there are a couple of questions from Avian.
And report I felt profoundly helpful. Thank you. And what you said today, great deal of positives. Some of the indicators illustrate that there's still a lot of work to be done to dismantle those inequities in our workforce.
Yes.
A couple of hints. Is there opportunity to broaden the plan that to incorporate things like the high impact, all the high impact, the EDI NHS high impact action areas, and things like being disability confident or 2 ticks employer? So there's that, pushing you on that. And the second bit is incorporating all the recommendations of the messenger review, in particular, given what you just reminded me, reciprocal mentoring, talent management plan, alongside that, targeted mid-career program for managers to embed their cultural understanding and competency. Can we do that?
Do you want me to help with that, or are you?
We have a couple of them ticked off already. I'm glad to say this year we achieved the highest level of the disability confidence scheme, so we are disability confident. Reciprocal mentoring.
The high impact actions,
The high.
which we already have embedded within our EDI plan. So we already have that covered, and we report that quarterly to policy committee and the ICB. So
Including also a review of our recruitment and retention.
it's all.
Good.
One final piece of this regional work to improve the global majority of our nursing AHP staff and later.
Again,
Okay.
another question.
Yeah. Let me try and be quick. So I've got 3 different questions, 3 different areas. Okay. This is a fantastic set of results. Really, really pleased that we're making, progress on, on those things. Do you want to draw a little bit of attention to Res 1.8, the one about discrimination from harassment and discrimination from above? So obviously we know that even though we may be improving on some of the other things, actually, if someone is feeling discriminated by their boss or harassment from their boss, that kind of almost negates some of the other stuff. Then they're not going to feel confident enough to go forward. And I just wanted to understand, how we're dealing with not just the people who are affected and how they are feeling, how we're dealing with the bosses to make sure that this is not an issue, because you can lean in as much as you like, but if you're feeling that that might be problematic. So just trying to get a bit of assurance of what we're doing, dealing with the bosses. Another issue, we've got a corporate review that we've started. Just making sure that as we're doing that we're taking on board all of those. I know we have the equality impact, but just staying, let's just double check, triple check that we're not just looking at race, but also looking at people like long-term conditions. And if we're trying to move people into different roles, are they able to take on that role? Are they feeling they might have to take on that role or lose their job? But actually, maybe we've not taken on board what their needs are, so that no one feels that they have to take on what they need to meet their need. And then lastly, there's a lot on racially minoritized and things like that, which is great. Just double checking that we're also meeting the needs of people with long-term health conditions. So, for instance, I don't know, someone I met recently has sickle cell and they get cold. We know that most of this have centrally controlled. So if someone who had sickle cell who's cold was in this room, we'll all be fine, but they may be shivering and not be able to concentrate. They're just wondering how we're going to be able to take, how are we taking those needs into consideration, so that they don't feel they have to go and find a room by themselves to keep.
Also, really excellent question. Can you take?
Yeah, I'll take all 3. Okay. So with Res 8, 14.3%, when we break that down further, the driving number in there is actually the discrimination and harassment faced from public and service users. And we see that reflected in our very high numbers of, being a mental health trust is already an indicator. And we have a lot of our racially minoritized staff are in lower bands. So the numbers then make sense that in people reporting facing aggression from patients and service users, it will come from that crop. So those are the things that contribute to the statistical anomaly in that regard. And that's where the work we're trying to do, and it's coming to people and culture around how we support our staff who experience violence and aggression, but within the context of recognizing that we're mental health trust, which is slightly different from how you operate in an acute setting. So it was just to point that out, and there is a body of work we're trying to do with security, Ops of Cavell, which is the deputy chief nurse leading on, and that the team sort of feed into. And recently Emma helped prepare a draft of a letter that can be shared out to staff managers in terms of how do you have this really difficult conversations with people who may not always have full capacity. So there is understanding that as well. But the driving factor isn't the managers, it's the service users. But where we do have it being the managers, Teresa and I lead on the employee relations cases or any conduct case. So that would automatically be a conduct thing. And I think it's safe to say that it's a reason in other trusts you don't have a CPO and a CNO do that. But here it's because we're absolutely clear that we're applying, I think it's safe to say, it's a no-nonsense approach to that. Your second question, which is
it's a corporate review.
The corporate review. There is a core part of the corporate review. So we have the policy impact analysis for all of the within each of the programs. But if you look at the feedback form, every person who's impacted by it, we have built into the feedback form, the section that asks about any of this, if they are aware personally, so they have the opportunity to self-declare. If there's anything they feel will disadvantage them through the process, and that all feeds in centrally. So there isn't an opportunity for anyone to misinterpret what someone has said or how someone has identified what their needs are or their reasonable adjustments. And so that comes centrally to the team. And the third question, which was
long-term conditions.
The long-term conditions within our orders, that is the part that we're still unpicking with regard to the ability to support people. So it's not, we're really good in this trust nationally at people being able to say, I have a need, I have a problem. So that's less of a problem. As Emma said earlier, the bigger problem we have in this organization is culturally giving the managers the confidence to know what to do and where do they draw the line between, can I do that, can I not do that?
Yeah.
And so that's where we are constantly aware of, and the team, actually as execs in January, we're having a reasonable adjustments. It's a regular thing that we talk about here in the trust. So we feel fairly confident, and I use the word fairly, cautiously optimistic, that we have our eyes in the right direction looking at it, but also because we've recently won a national award for just that. And Emma's team have been leading on that. So they are doing fantastic work.
Yep. Great set of questions and well answered. Thank you very much, Emma. Thank you so much for the work you're doing and more to do, but thank you so much for the brilliant support. Moving on.
Thank you.
We are slightly behind, but actually, if we can't spend a bit more time on quality reports and race equality standards, then we've not probably got our priorities right. So I'm really grateful. Thank you. If we could take the annual operating plan, and then we'll have a short break. Colin.
Thank you, Chair. So this is the update to the annual operating plan that the board signed off at the end or the very beginning of this financial year. Obviously, because of sequencing, it's a month 5 position, recognising that we're literally only just out of kind of sort of quarter 2. And people remember that it's a synthesis of different elements of our kind of sort of delivery plan in this year, and it's something that we've been evolving over the last kind of sort of couple of years. Principally, it looks through the lens of where are we in terms of the achievement of the breakthrough objectives that were established? How does that then sort of triangulate and align through to the quality plan, our improvement, our transformation kind of sort of priorities, finance, activity and performance, of which we have more substantive items later on the agenda, and then also developments in terms of sort of the people and culture plan itself. Just in terms of very brief summary, I think it's fair to say that there has been, overall there has been relatively kind of sort of good progress against the areas of ambition, recognising that in a number of areas we've got good progress in terms of change, but we need to then start to look at the measurability of some of that change in terms of actually, okay, has that translated into the outcomes that we were absolutely expecting to see? The quality plan in itself is looking kind of sort of positive. The improvement priorities, I think it is worth noting, I know Jane referenced it at the start, of the fact that we have our 3 main cases for change now agreed with our ICB partners. So that is about community transformation, transformation of our rehabilitation, inpatient and community services, and dementia as well. And just to note the huge work that the clinical and operational teams put into producing those things. I think they were really good quality pieces of work within a time frame. Obviously, critical for us now is the movement to implementation, and being able to really bring our staff on that journey with us. The only other point I think just to probably kind of sort of note is there's one of the 3 breakthrough objectives is the one area that we are not achieving, and I'm sure we'll pick that up shortly. And then the only other kind of sort of area of sort of small concern is around one of the access standards, which is also in the performance report with the detailed narrative. Overall, I think it is a kind of a sort of a good position against where we are for this year. Happy outside of it to take feedback in terms of structure and presentation of this, recognise that this will be straightforward as we then think about it in the context of the new strategy. I had to get that in somewhere. But yeah, happy to take questions.
Thank you. Well done. I mean, it's good, the progress being made, particularly alongside the financial recovery plan and other pushes that we have. So thank you for that. Eddie? Just two questions then, and then we'll close up. So, for a break, and Simon.
Being a newbie, I don't know if this template is standardised across the NHS, but I thought it was brilliant and I learned a lot from it, so thank you. The third breakthrough objective is the reality down solely to a trade-off of delivering our financial plan. And if it is, given the current financial realities, is it entirely fanciful for us to think that we're going to deliver it?
The issue with outcomes is we've had to change culture, had to change practice, and we've had to build systems within which to get the reporting correctly. So we've got a central corporate team that have worked extremely hard on starting to build some of that system architecture. The key delivery piece will be System 1 when System 1 comes live for us. That's what's going to allow us to do this with relative ease and report it well. So I will own also the difficulties around the health inequalities piece, particularly, we touched upon it last time, our ability to record and report ethnicity or deprivation, which we've looked at in the Quality Committee through the lens of 420+5. We've reworked our approach to this on a couple of occasions because we've had some change in personnel. There's been some pressures through the way we've chosen to reorganize. But actually, the delays, I think, have probably been to our advantage in that we haven't pursued single silos approaches to this. We've got this narrative now, which is we need to know something about the individual characteristics of the person that we're seeking to treat, their ethnicity, their background, their particular needs, their deprivation indices, and so on and so forth. We need to pull that through to the way we describe them in terms of diagnosis, formulation. The big emphasis that we've talked about a lot in Quality Committee around care planning and risk assessment and how we get that right. The care we then set and then the outcomes that are then delivered. But I have to say the last round of divisional meetings, I listened to the last QPR round I heard more coming back about the progress and the struggles that they're having in helping us work out how to get that information on outcomes back to us. So I would love to say it will be done by the 31st of December for obvious reasons. I think this will be going well by April, and I think System 1 will be the difference between it going well and us debating whether we're 95% compliant or not, if I'm honest.
Yeah, no, it's honest. It's what we want. Thank you, Peter. Jane, do you want to?
I think I need to be clear as well. I think we can do it within the context. I think what's happened is we've taken the eye off the ball on these, if I'm honest, that we've been focusing on other things, and then I think we've been, drat, we haven't done this one in the way that we should have done, and that's on all of us as an executive team. We've taken the eye off the ball on this. So we've had quite a robust conversation at Exec Committee about how we are going to take this forward in the next 2 quarters to recover the position. But we're doing it within the context of major change within the organisation. So there is a caveat there, but I am confident we will be moving forward on this. But I want to be clear at the off the ball. There's no excuse.
This might be a little bit like asking a question about paper clips, so apologies if it is. It's all about smoking, because in a sort of a national and principled way, the stopping smoking is a very obvious thing and getting behind it for all the right reasons. But on the trips that I've been to out to services, it's very clear that it's actually much more complicated than that. So I was just interested in whether what it means to be at risk in this area, given that sort of interplay between people with mental illness and smoking and the outcomes and the legislation that's coming through or potentially coming through in relation to.
Best to answer that as a
probably treat.
Following that. Okay.
So I think, in the spirit of candour, organisations outside of Sussex have been smoke-free for many, many, many years. And when I arrived here in Sussex, people would say to me, we're smoke-free. And I would go out into services and instantly see people smoking, whether that be staff or patients, on sites, whether that be on the edge of a site, whether that be outside the hospital site, that's what I would see. And we weren't challenging it.
we were challenging it. And so this takes leadership, and it takes leadership to be able to say to the next person, we're a smoke-free site, we need to move from here. And there's been very little of that. So, you know, that's certainly something that you can be expecting from all of us, and I would encourage that we should all be doing that. We have some patient safety incidents that are more profound for patients that are smokers than not smokers. So we're updating currently the smoke-free policy and also looking at that in alignment with the Section 17 leave policy. That's a really important factor. So I think we're making progress, but it takes local leadership.
But let's just take us no level.
Teresa's covered the point about policy. I guess what I was going to say was we're also working with our partners as part of the sort of alternatives to smoking. So we've pushed the sort of vaping quite a lot. We're giving them out free. We do all the collections as well in terms of reusable. So we're looking, we are trying to work, you know, recognizing that it isn't just as, you know, as much as we might like, just sort of people not smoking. The point you made, there is a high link between people with sometimes a mental health condition and smoking. And so I think that program around vapes, alternatives to smoking, and sort of pushing that program, we've been rolling it out this year. It will continue into next year, and sort of we'll continue to work with the teams and the programs to, I guess, implement as much as we can, recognizing the challenges that Teresa's talked about, that actually we are going to still have to make that challenge around, you know, it is recycling.
Thank you. More than paper clips, yes. Thank you very much.
Can I just add one sort of bit there? So obviously, red, yellow, and green isn't as important as what action is going on behind it. But I would like to think that what you've just described is amber rather than red. If we've got the alternatives through, I feel slightly uncomfortable with the idea that it is red and that we're happy with it being red. And if it is genuinely red, then I think probably want to think a bit more about it. But what you've just described doesn't sound wholly red to me.
A very brief anecdote, because I have shared with the board before that I have a first cousin who I know learned since a little child who's got severe and enduring mental illness and been an inpatient in a number of our facilities. And a year ago, I joined him for a cigarette in the garden. This year, when he's been admitted, he phoned me to say he'd run out of money to buy vapes. Could I send him some money? And I was able to tell him he'd be able to get his vapes, to get his nicotine without any problem on Bodine Ward. And he's been brilliantly looked after. So that's changed in a year for him.
Yeah.
And it's been a good change. And the vaping side of things has made a huge difference. Thank you.
And given our discussion, can we review the voting?
Yeah, we do. Thank you.
Okay, thanks very much. We'll have a 10-minute break and then we'll come back.